the exact date. And so this morning, I have it pulled up here too. This morning we'll talk about, are y'all comfortable with calculating GTPALs and all that? You're comfortable with that? Mm-hmm. So I'll skip that piece, and everybody's comfortable. Y'all know how to do that. Okay. So I'll skip that piece because that'll save us some time. And throughout the PowerPoint, we'll have some questions and stuff too that you guys can participate and answer. So we'll talk about hyperuresis gravida, ectopic pregnancy, hypertension and pregnancy, and the HELP syndrome. So with hyperuresis gravida, this is when someone's constantly throwing up when they're pregnant to the point where they eventually have to be hospitalized. And so when you're thinking about nursing interventions or what's most important for them, what would your mind go to first? Exactly. And that's generally where your questions will be coming from. Not, I can't say where they'll be coming from, but generally whenever you're thinking about someone losing a lot of fluid volume or throwing up a lot, you're thinking about just hydrating them, because if it were anyone else who wasn't pregnant, you would want to treat that cause, but since the cause is pregnancy, you don't want to terminate the pregnancy over something like that. So women will get this syndrome. Sometimes they'll be admitted more than once, just depending on how bad their case of it is. And so you guys have a pretty good understanding of this issue. Mm-hmm. Okay, so I have a question. A 21-year-old client, 6 weeks pregnant, is diagnosed with hyperuresis gravida. This excessive vomiting during pregnancy will often result in which of the following? Is it A, bowel perforation, B, electrolyte imbalance, C, miscarriage, or D, pregnancy-induced hypertension? Correct. And that's for the reason we just talked about with that one. So let's discuss ectopic pregnancy. An ectopic pregnancy occurs when a fertilized egg is implanted anywhere outside of the uterus. And with an ectopic pregnancy, the larger the pregnancy grows, the more the person is at risk for bleeding or rupture of their tube if it's in their tube. So what would be some nursing interventions? Like, what would you think would come to mind with these people? I'm sorry. Yeah. Okay, we would use that, but as a nurse, what would you be looking for with this client? Like, they're coming in the emergency room, they would be complaining of pain on one side. What else? Pressure, cramping,
positive pregnancy test.
Spotting, positive pregnancy test, exactly. So, what would be the age range would you be looking for in these people?
Maybe 35.
Yeah, like less than 19 or higher than 35, right?
Mm-hmm. Okay. With the ectopic pregnancy, these women may not notice anything at first. They'll have the usual signs of pregnancy, a missed period, like you said, a positive pregnancy test, maybe some nausea and vomiting in the morning, but everything else will be pretty much normal with them until a little bit later as the fetus develops. And we're worried about shock in this patient population because when it does rupture, it will cause hemorrhaging and bleeding. So what would be some risk factors of someone who would have an ectopic pregnancy? Exactly. If you've had one before, not more than likely, but you could possibly have another one just depending on how your anatomy works. If you have any STDs or STIs that go untreated for a long time, they cause damage to your reproductive system. That's also a risk factor of having an ectopic pregnancy. People with the IUDs, they are at risk for ectopic pregnancies as well because the IUD is in place and then it won't allow the egg to come out normally if it is fertilized. People with failed tube ligations, they're at risk for ectopic pregnancies for the same reason as a person with the IUD. It just doesn't allow the egg to travel normally. Also, people who smoke cigarettes can be at an increased risk for that because I guess the damage it does to your organs or to the arteries, I would say, to your arteries. So, what would you expect to be some orders from a doctor? How would they diagnose an ectopic pregnancy? I guess I should be like not showing y'all the answers first. Exactly. Have y'all seen that here or not necessarily? I don't know if you've had one, but if you've seen it here. So it's like a wand that they'll insert into the vagina and it just gets a better picture and you can see earlier pregnancies or just a picture of the uterus if there's anything growing there, or you can see your ovaries with that as well. So with the treatment of it, you talked about the methotrexate. Do you guys know what that is and what it does?
It'll like liquefy
Mm-hmm. What else could they do for an ectopic pregnancy? Mm-hmm. So with post-op patients, what do you look for with them? What type of care? Risk for infection, you said.
Risk for bleeding.
Risk for bleeding. What else? Exactly. Pain management. Let me see if I missed anything. They'll also be following up with HCG tests to make sure that all parts of the ectopic pregnancy were removed. So they'll keep doing it for like a couple of months, I think, for this one, or a couple of months, and then you're advised not to get pregnant within at least a year after having an ectopic pregnancy. So we talked about that. Have y'all seen, not necessarily with the ectopic pregnancy, but like a laparoscopic procedure before? Y'all do a surgical rotation? Okay, so that's pretty cool. It's they'll just put like small incisions instead of like actually cutting someone open. If it's actually ruptured, they're gonna go ahead and like cut them all the way open. But if it's on the verge of rupturing, they'll do the laparoscopic procedure, which is really neat if you've had a chance to see one. And again, that's the emergency surgery. Okay, so a woman is admitted to the hospital with a ruptured ectopic pregnancy. Uh, Laparotomy is scheduled preoperatively. Which of the following goals is most important for the nurse to include on the client's plan of care? A, fluid replacement. B, pain relief. C, emotional support. Or D, respiratory therapy.
C.
It says C. Anybody else want to answer as well? So we have one C. Okay. And one B. Two B's.
Wait, before you go. Laparotomy, is that laparoscopic? Mm-hmm. Okay, yes. So my answer is
Still saying C? Okay. You want to answer? Try to answer. Okay. So the thing with OB questions is that they'll kind of try to throw you off by making it like OB, but you still want to think about what would anybody do post-operatively, and that would be A for fluid replacement. So that's the trickiest thing with questions about maternity is that they'll throw this like maternal piece into it, but you still have to look at them like as a human being basically. And what would any human need before they went into surgery? Because this person's already been bleeding. If it has ruptured, they've been bleeding. If not, once they get into surgery, they're going to have some type of bleeding. So you want to make sure that they're hydrated before they go to surgery. And this is the rationale for it. So a fluid replacement makes sense because the client has a ruptured ectopic pregnancy. An ectopic pregnancy is implantation of the fertilized ovum at a site other than the endometrial lining. Usually the fallopian tube is where they take place. Initially, the pregnancy is normal, but the embryo outgrows the fallopian tube. The tube ruptures, causing extensive bleeding into the abdominal cavity. Choice 4, respiratory therapy does not make sense with a ruptured ectopic pregnancy. The obstetrical client is not likely to need respiratory care prior to surgery. After reading these questions, many students selected answer choice C and D, which was 2 and 3. Two and three as the correct answer. They justify this by emphasizing the importance of managing this woman's pain or addressing her grief about losing the pregnancy. However, neither answer choice takes priority over the physiological demand of fluid replacement prior to surgery.
So, just a question. Was that question post-op or pre-op?
Pre. Before surgery.
I read post-op.
Pre-surgery. So yeah, that's just the most important. Just kind of take the OB stuff out sometimes, because they'll always have a distractor of like, emotional support or pain management or whatever. But just kind of block that out sometimes. So maternal hypertension will be our next subject. So there's 4 kinds. I'm not sure you guys talked about. I know preeclampsia and gestational hypertension. Did she go into detail with it or just those 2? Okay. So with gestational hypertension, and it took me back to ectopic pregnancy for some reason. Let me see. So women with gestational hypertension have high blood pressure that develops after 20 weeks of pregnancy. There is no excess protein in the urine or other signs of organ damage. Women with gestational hypertension eventually develop preeclampsia. So the defining factor that'll separate gestational hypertension from preeclampsia is that it develops after 20 weeks of pregnancy and there's no protein in their urine. And protein, like I said, is a representation of organ damage. Whenever you start seeing protein or ketones spill into the urine, it means something else is going on, something more serious. Chronic hypertension is high blood pressure that was present before pregnancy or that occurs before 20 weeks of pregnancy. But because high blood pressure usually doesn't have symptoms, it might be hard to determine when it began. So if they have chronic hypertension or if they're already taking blood pressure meds and they get pregnant, then they would fall into a chronic hypertension category. Chronic hypertension with superimposed preeclampsia is a condition that develops in women who have chronic hypertension before pregnancy who develop high blood pressure and protein in the urine during the course of their pregnancy. So if they had it before and now they're developing protein in their urine, then it would be chronic hypertension with superimposed preeclampsia. But I've never seen it written this way on a test that I've taken. So I wouldn't stress about this one. Preeclampsia, which will be the most important for you guys, is hypertension that develops after 20 weeks of pregnancy and is associated with signs of damage to other organs, including the kidney, liver, blood, or brain. Untreated preeclampsia can lead to serious, even fatal complications for the mother and baby, including developing seizures, which would be eclampsia. So once the patient starts having seizures or their blood pressure is so high that they're having issues more so than just the urine spilling, they're entering eclampsia, which you usually don't hear about eclampsia because they try to stop it at pre-eclampsia, if that makes sense. So With hypertension, you have decreased blood flow to the placenta, placenta abruption, interuterine growth restriction, injury to your other organs, premature delivery, and the future risk of cardiovascular disease. So what do you guys know about placenta abruption? Like what is it? What happens?
It comes off like that.
Mm-hmm. So there is a lot of bleeding that's associated with this, and it literally is when the placenta just comes off or comes partially or completely detached from the mother's womb, and it can happen because of hypertension or other things can cause it too, like injury. If there's like a car wreck or something like that, you can have placental abruption. But for the purposes of just talking about hypertension, preeclampsia causes this to happen. Decreased blood flow to the placenta from hypertension, just because there's damage to your arteries and cardiovascular system, is why there would be decreased blood flow, and that the pressure is so high that it's just not perfusing the baby properly. Interuterine growth restriction for those same reasons. If the placenta isn't perfused properly, then the baby's not going to grow because they're not getting the nutrients that they need to grow. Injury to other organs for the same reason, because the vascular system's compromised, and so nothing's being perfused, which causes tissue death. And premature delivery, because the cause of the hypertension is the pregnancy. So they'll either opt to deliver it if the baby's able to survive outside of the womb, hopefully, so if they're far along, that can happen. Or sometimes, if it's earlier than that, they'll terminate the pregnancy if it's that life-threatening, but it's up to the mother and father. It's up to the parents. And risk of future cardiovascular disease. So people really don't know why it happens, but because the damage, and so the damage that it causes to the body puts you at risk for future cardiovascular disease. Also, the fact that you developed it anyway shows that there's some underlying risk factors for having a cardiovascular disease. So management, what are some ways that we can manage preeclampsia? What are some drugs that you guys talked about? Mm-hmm. Which ones? Do you know any?
Labetalol, Procardia, and that one, it starts with control. Not that one. It was like, I think it starts with an A. I think it's either an A or an E. It's something that I couldn't say.
Norvasc or amlodipine?
Not amlodipine. I know that. I don't remember.
The nifedipine?
It's on my notes. But it's the first one that she mentioned during lecture. And I was like, well, I know it if I see you, because I can't say that.
I know with hydralazine it causes some issues, so they're careful about that one. But typically, and I guess it's not a trick question, but typically any blood pressure medicine, other than some of those that are labeled specifically don't use, will do. It just depends on the woman and her body type. I've seen literally all types, HCTZ, Norvasc. It just depends on the doctor, what they're comfortable with, and they'll taper the order for the specific client. So it really doesn't matter. But for some reason, I feel like hydralazine is one that they don't use, and I'll look it up before I leave and let everybody know. Because it's something about hydralazine in pregnant women I can't remember specifically. You want to keep your prenatal appointments. You want to stay active, eat well, and of course, don't smoke. And of course, don't drink alcohol. So They also use magnesium sulfate, which is something that you guys will focus on with some of the test questions will come from the magnesium sulfate, I'm sure. And so this medication is used to prevent seizures. Magnesium sulfate can help prevent seizures in women with postpartum preeclampsia who have severe signs and symptoms. Magnesium sulfate is typically taken for 24 hours. After treatment with magnesium sulfate, your healthcare provider will closely monitor your blood pressure, urination, and other symptoms. And hopefully this video works because it's a good video. And it'll kind of show how people with preeclampsia present in the hospital setting.
Fetal thrombocytopenia.
What was it?
It causes fetal thrombocytopenia, but
Okay.
it's still reasonably safe. So I guess it's used with caution.
This works. I will load this video up because I do want you guys to see that lady because it's a good learning opportunity. But I'll wait until after we're finished since it's not loading up. I think I have to like log back in to move on, whatever. So, what are some nursing implications for using mag sulfate? What would you think to look for in the patient? What would too much of it look like in the patient?
Like super lethargic.
Mm-hmm.
Low respiratory, like 14.
Low urine output, less than like 30 an hour.
Mm-hmm.
Maybe headaches before.
Bradycardia.
Yeah,
Everything just slow.
exactly.
Everything just.
So it is a CNS depressant. And one big thing that you guys did talk about in class was what is also depressed. Exactly. So with this patient, you're going to monitor their pulse, their blood pressure, their respirations, and ECG or EKG monitoring may also be warranted for this type of patient. The respiration should be at least 16 breaths per minute before each dose. And you're monitoring, you're doing neural checks before and during the therapy. You're going to institute seizure precautions. Patella reflex should be tested before each dose of magnesium. If the response is absent, no additional doses should be administered until a positive response is obtained. So if they don't have any type of knee-jerk reaction, then you're gonna want to not do any more mag sulfate with the students.
Like big reflex. Is that still a bad sign for it?
No, that's normal.
Well, they said +3 was bad.
Well, plus 3 means that it's being ineffective. So if you're at +3, then it means it's not, the magnesium's not effective on their preeclampsia.
I know
They
it's
need
bad.
more. And if there's none at all, it means it's too much. And so a question, let me see if I added this question.
What if there
to
is
this.
deep tendon reflex, but it's like really like faint?
That's fine too.
That's fine.
That's fine. That's normal. That would count as normal too. So if you have a patient and they're on mag sulfate and you're doing your deep tendon reflexes, they don't have any, and their respirations are below 16, and they're doing all of these classic signs of having too much mag sulfate, are you going to exactly, you stop it first and then call the provider, because the time it takes for you to get in touch with the provider while it's still running is still decreasing them, and you might end up running a code before you can get in touch with someone. So that's one of the times where you can go ahead and switch it off and then call the provider and say, hey, this is what's going on with the client, this was a change in their condition, and then he'll order some other stuff, or could order some other stuff or some other interventions for you to do. Okay. Oops. When administering mag sulfate to a client with preeclampsia, the nurse understands that this drug is given to do which of the following: A. Prevent seizures. B. Reduce blood pressure. C. Slow the process of labor. Or D. Increase diuresis. So that's right. A client is diagnosed with gestational hypertension and is receiving magnesium sulfate. Which finding would the nurse interpret as indicating a therapeutic level of medication? A. Urinary output of 20 milliliters per hour. B. Respiratory rate of 10 breaths per minute. Deep tendon reflexes plus 2. Or difficulty in arousing.
See.
The answer is C. Okay, so HELP syndrome. So preeclampsia can lead to eclampsia and also HELP syndrome. And so HELP syndrome is thought to be a variant of preeclampsia, but it may be an entity all in its own. There are still many questions about the serious condition of HELP syndrome. The cause is still unclear to many doctors, and often HELP syndrome is misdiagnosed. The H in the HELP syndrome stands for hemolysis. This looks for blood ruptures. What you are checking with the test is decreased hemoglobin, hematocrit, and red blood cell counts. EL stands for elevated liver enzymes, specifically AST and ALT. This means that there is some liver damage present when you start seeing those enzymes elevated in your blood levels. And LP is for low platelets. If the platelets are below 100,000, then you have a problem. You're in serious trouble at that point. So, what are some symptoms of HELP syndrome? What would they complain of if they're presenting to you in the ER? What would that look like? Mm-hmm. Headaches. What else?
Maybe very like fatigued.
Vision changes, fatigue. So
Jaundice maybe.
Mm-hmm. Depending on how far along they are with it. So you want to think about anything like the preeclampsia symptoms, but with the liver aspect to it. So anything that you would have with preeclampsia as far as vision changes, headaches, blurred vision, any high blood pressure symptoms, they would have that, and then the jaundice piece as well, because there could be possibly some liver damage. And then they will also have the protein in their urine, swelling, and they could be presenting with some bleeding as well because of that blood count being low. So these are some of the labs that they would look for. I don't think that they'll have anything. You could definitely know the bilirubin would be less than 1.2 milligrams per deciliter. That's something as far as labs to know. I don't think she's going to go into all of this here. And then the low platelet count is a bleeding risk. So the treatment of HELP syndrome is primarily based on the gestation of the pregnancy, but the delivery of the baby is the best way to stop the condition from causing any serious complications for mom and baby. Most symptoms and side effects will subside within 2 to 3 days after delivery. If the pregnancy is less than 34 weeks gestation, doctors usually try to evaluate the lung function of the baby to see how well it would tolerate delivery. So if it's less than 34 weeks, they're looking at how well can the baby survive. And so what would you think they would give the mom? The steroids, exactly, to develop the lungs. So some treatments for this would be bed rest and admission into a medical facility, corticosteroids to help the baby's lungs develop, magnesium sulfate, you said that one, to prevent seizures, a blood transfusion if the platelets get too low, blood pressure medication, and fetal monitoring and testing. And If the pregnancy is more than 34 weeks of gestation or the symptoms of health begin to worsen, then they deliver the child. So I was reading where I guess in the past they always used to do C-sections for these women, but that's not the case anymore. They'll let them have a trial labor, and if it's not successful or they're not progressing well, then they'll do a C-section. But this isn't a guaranteed C-section like it used to be maybe 10 years ago. These are some risk factors. So if you have preeclampsia or pregnancy-induced hypertension, you'd be at risk for this. Women over the age of 25, Caucasian women, and women who are who have given birth 2 or more times are at risk for developing this syndrome. So the most serious complications are placenta abruption, pulmonary edema, disseminated intravascular coagulation, and that's a blood clotting problem that results in hemorrhage, adult respiratory distress or lung failure, ruptured liver, acute renal failure, intrauterine growth restriction, and infant respiratory distress or lung failure. And then, of course, they're at risk for having a blood transfusion. So, this is our question. The nurse is reviewing the laboratory test results of a pregnant client. Which of the following findings would alert the nurse to the development of HELLP syndrome? Would it be hyperglycemia, elevated platelet counts, leukocytosis, or elevated liver enzymes?
D.
Yep, that's correct. Yeah. I said, do you guys have any questions about any of? I know we went through it kind of fast, but any questions about any of these issues or diseases? If valid, okay. And it made sense?
Yeah.
A bit?
It's timely for their test, right? You timed
Yeah.
it out really well.
All right, well, thank you.
Thank you.
Thank you,
I
thank you.
wish I could have heard all of it.